Morning. So, welcome. My name is Ruth Bailey. I'm a non-executive member of the board and will be chairing today's meeting. I'd like to welcome everybody to our second meeting of the South West London Integrated Care Board. Can I remind everyone that the meeting is being broadcast online and recorded. The recording will be uploaded onto the ICB website after the meeting, and British Sign Language will be available on the website. Can members remember to use your microphones? It's probably the thing that will trip me up. When you speak, for the benefit of people at the meeting as well as the recording. A hearing loop is available should anyone need access to it. Can I remind everyone that this is a meeting which is being held in public, but not a public meeting. We're not expecting any fire alarm tests today, so if the alarm does sound, we will all need to leave the room through the emergency exits marked in the room or through the main reception and assemble in the fire assembly point, which is the grassed area at the end of the car park marked with green signs. We will all do our best to avoid jargon and acronyms, but a glossary of terms is available on the ICB website and included on chairs for members of the public observing the meeting today. Questions from the members of the public will be taken at the end of the meeting. In terms of apology, we've received apologies from Martin Spencer, non-executive member, Dame Callie Palmer, partner member for Specialised Services, Joe Farrer, partner member for Community Services, Nicola Jones, partner member for Primary Medical Services, Ian Dodds, place member for Richmond, Annette Poltz, place member for Kingston, and Mark Krillman, place member for Wandsworth. And then we have two people who will need to leave us at 12:15, Matthew Kershaw and Ruth Dombey. And so with no further apologies, the meeting is forward. Moving on to item 2, declaration of interests. You should all have a copy of the declared interests in your pack of papers. Could I ask members to declare any additional interests not on the agenda, not already on the register, and any interests arising from the agenda or papers presented for the meeting today?
Ruth, can I just raise the fact that I'm a member, non-executive director of the Medicines and Healthcare Products Regulatory Agency. There's no clash with anything on the agenda.
Thank you, Mercy. Thank you. So, item 3, minutes, action log and matters arising. So these are the minutes and action arising from the ICB meeting held on the 1st of July 2022. The minutes of the previous meeting are included for approval. Does everyone agree that they are an accurate reflection of the meeting? Thank you. I understand all the actions on the action log are closed except for one relating to Children and Young People Board in SWL. Gloria, can you give us a brief update on the action relating to the development of Children and Young People's Board in SWL?
Thank you, Ruth. We started the board just before we became ICS about around May time this year, and it's co-chaired by a director of Children's Services and myself. So again, in preparation to become an ICS and to integrate strongly. We are going from strength to strength, and we have schools. It's sort of like represent the whole population. There are 5 key things that we are focusing on. One is looking at complex care need for children, and also we are looking at send and transition. Those are our key priorities. Also, in terms of physical health, we are looking at asthma, which is part of the London and regional priorities. And I think finally we are looking at parenting, just thinking about using family scope. Not just the children, looking at the whole family as a whole. Thank you.
Great, thank you, Gloria. That sounds really excellent. Sorry, that sounds great. Thanks, Gloria. Any further issues?
Just one small point. Item 2, we've agreed to receive the primary care strategy next March. So the item's closed in the sense that a decision's been made, but probably a good idea to just keep it on the log so we remember come next March.
That's great, we will do that indeed. Can that be noted, please? Any other comments on the action log? Great, thank you. So, the board approved the minutes. Decisions made in any other meetings. So, a Part 2 meeting of the board was held on the 21st of September 2022. Part 2 meetings allow the board to meet without the public to discuss items that may be business sensitive and matters that are confidential in nature. For transparency, the decisions made in other meetings are brought today for the board to note in public. So these are: the board approved the allocations of NHS England winter funds against the proposed scheme across South West London for urgent and emergency care. The board approved a request for a tender waiver to extend the current urgent care services model in Croydon for 12 months. To ensure continuity of service across South West London GP practices, the board approved a contract award to Egton. 2 contract extensions for ICT transition support have been agreed by the ICB CEO and Chair of the ICB Finance and Planning Committee following discussion at the ICB board. And then finally, as part of the process for the consideration of the delegation of pharmacy, optometry and dental services from April 2023, in line with other London ICBs, the completion of a pre-delegation assessment framework has been agreed to be delegated to Sarah Blow, CEO, and Mark Creelman, SRO for primary care. The delegation process and the decision for the board will be set out at a future board meeting. The board is asked to note the decisions made in other meetings. Is everybody content to do so? Thank you. Item 5, Chief Executive Officer's Report. Sarah, I'll ask you to now speak to this item.
Thank you very much, Chair. So just a few items on my report. One was just to bring to people's attention the BBC Panorama report on mental health services, just to give assurance that we are working across our 2 mental health trusts, South West London St George's and SLAM, to look at a review of those inpatient services to make sure that we are looking after those patients appropriately. There was a letter that came out from Claire Murdoch, who's the National Lead for Mental Health, asking all mental health trusts to do a review. So just to let people know that we're looking at that. Secondly, I just thought we would update on the Secretary of State, or the current Secretary of State, I should say, priorities for health and care, which is the ABCD, for those of you that haven't seen that, and that's ambulances, backlogs, care, which is how we work with our local authorities around social care, doctors, but mainly focused on GPs, and dentistry. So those are the kind of ABCDs for the current Secretary of State. Chair arrangements, just so everyone is aware that obviously our previous chair has resigned and stepped down. Ruth is chairing today. We are in the process now of appointing a new chair. An advert did go out last week, so I'm giving you an update from my report because at the time of writing it hadn't gone out, but it has now gone out to advert. And London Health and Care Partnership, well, Dick and I were both at an interesting event on Tuesday where we went to central London and met with local authority colleagues, colleagues from the voluntary sector and other people in the health service to look at integration across London and how we might work together going forwards at a London level. So Dick and I both attended that. It was a very interesting day and I think more work for us to do together across London.
Thank you, Sarah. Any questions for Sarah on the back of that update? Thank you. So the board notes the contents of the report. Item 6, Delegation of Specialised Commissioning Pre-Delegation Assessment Framework. I'm going to ask Jonathan Bates to speak to this item. Jonathan.
Thank you very much, Ruth. I'm speaking to this item on behalf of Lucy Waters and the specialist commissioning team across South London who are unable to be with us today. So this paper, and hopefully colleagues have had an opportunity to review it, talks about specialised services. Those are complex care pathways for patients, and it sets out how we intend to devolve or delegate 65 of them to the local ICB from NHS England. There's a total of 150. Some will never be delegated because they're such rare conditions. Some are not yet ready for delegation, but a significant number are, and in terms of financial value, they're also significant. And I think this is important for three reasons. It's important for whole pathway care, for end-to-end care pathway treatment for patients. It's important for removing barriers to access, including addressing health inequalities. I'll come on to give examples of those in a moment. And it's actually important to our local providers who sit around this table too, particularly to St George's and to the Royal Marsden, who have significant flows of specialist care, though all our trusts do to some extent. I think it's also important in noting the pre-delegation assessment framework, which is the process that NHS England is asking us to work our way through at the moment. There is no status quo option, so we cannot stay as we are now. There are two proposals on the table, one about a joint committee arrangement, where we would sit around the table with NHS England in relation to decision making, and one where we would take delegation and responsibility and have a broader role and remit for the care of the local population. The paper sets out 6 areas, just to mention what they are. So the first is geography, so the bounds of this programme of work and working with colleagues in South East London, and how we would set up our joint working relationships as an ICB. It also notes our links into Surrey Heartlands ICB too, given the extensive flows for that population. It sets out plans around transformation, and if I have a moment or two, I'll mention a couple of those just so members of the public and members of the board can hear some of the potential gains I think there might be. The third area is governance, and this sets out how through the London Partnership Board and through the Strategic Oversight Group that Sarah will sit on and the Executive Management Board that I'll sit on, we'll continue to have oversight and effective governance arrangements in the local system. It sets out our proposals around money, which is obviously a key issue in relation to this plan, workforce, and in this context it's largely around delegation of staff associated with specialist commissioning services, of which there are only a handful in London, and a precious resource. And then finally about data and analytics, because it's more than 10 years actually since these services have been run locally, so we need to make sure we have the right data flows to understand and deliver that end-to-end care model I described around. In terms of the timeline for this, just so board members are aware, this isn't the end point. This is a draft submission. This pre-delegation assessment is a draft submission. It will go in tomorrow to NHS England. We're expecting feedback on the 26th of October and a final version by the 18th of November. That will then go through a national moderation process in December before NHS England make a decision at their board meeting on the 2nd of February next year. So that's the envisaged timeline in relation to this process. So there's an opportunity to flex the proposal in response to feedback we received from NHS England and indeed from this board. So just to touch on, if I may, a couple of examples I thought that were really pertinent around this. So by joining up end-to-end care for things like HIV screening, we've already been able to ensure that patients who arrive in A&E having an HIV test, we've been able to identify 95 people so far this year who did not know they had HIV. And that programme is being extended actually today in some parts of South London, some trusts in South London, to Hep B and Hep C patients. So that's a really good example. For sickle cell disease, where there are major health inequality issues, I think if you have access to those truly specialist services, they're great, but there's plenty of experience, and there's parliamentary reports actually on those who have not had good access to care, which is disconnected between what's commissioned by our predecessor organisations in primary care, urgent and emergency care, with what the specialist services look like. You could apply the same to the renal pathway, where we can join things up more effectively and do more prevention work at the beginning of the pathway. And there are a number of cardiac conditions. The one that Lucy, who leads on specialist commissioning for us, often talks about is a particular aortic valve procedure, a TAVI as it's called, where the research shows, even though there's no clinical evidence base for this, if you're a black male, you're 8 times less likely to have that than a white male in South London. So there's some examples of how we could change care pathways to address health inequalities by greater connectivity around what we do. So I think there's a real opportunity. I think there are risks, just to note those, and so the board is aware of those, and probably the three that stand out for me are the financial risk in relation to this, and understanding fully what we're inheriting will take a little time. What spend in specialised services pre-pandemic was going up about 7 or 8% a year. The reassuring part I take in this is the bit that was going up very fast, which was the high-cost drug spend, which was going up something like 27% a year, is not being delegated through this process. It's the rest of specialised services that went up about 1 or 2% in comparison with that rise. But it would be disingenuous not to be clear that there are further work to understand the data and the risks that sit around the financial aspects of this. There's a people risk, and this is one of the reasons we're keen to do this in London. There's a small and fragile team, literally a handful of people who are managing these services across London, and we feel that we could do more through the influence of the ICB and the ICS to support that and to strengthen that across things like finance and BI and quality. But it is an issue for people to note. And then probably the other issue is any legacy issues that might emerge, and that we're working through with NHS England how we might manage that, because you can imagine in 65 services coming across with a very small team managing them centrally, there are some risks that we might inherit something that we were not necessarily expecting. So there's some real advantages for the population locally. There are a few risks as I've articulated. We will continue to work through this, and the request is that the authority is divested to Sarah as the Chief Executive around signing off the final version of the pre-delegation assessment framework once that's finalised later this year.
Thank you, Jonathan. Really succinct summary. Could I ask if there are any questions? James?
Thank you very much for the summary. I suppose my reflection is that if we're being delegated from April 23, which is my understanding, then actually the work starts pretty soon, because we need to be in a planning round for 23-24, basically acting as if this has been delegated. So that leads me on to my question, which is, are we ready to mobilise the structures and processes and resources that are outlined in this, so that we're not sort of picking it up very late into the run into 23-24, but we're actually able to integrate it with the rest of our planning timetable for next year?
So I think, James, we're as well prepared as anyone is, I think would be my summary. So over the last 18 months or so, we've had an office across South London focused on specialised services and what we intend to do around supporting delegation in this space, and this is the sort of goal for what we're trying to achieve. It would be fair to say that we're working through internally, as I said a moment ago, what it means for quality, what it means for BI, what it means for finance, what it means locally. I think we've also tried to build and strengthen our arrangements. So I know there's a proposal for a specialised board for South West London, which people around this table would coordinate and chair. So I think we have the right arrangements in place. I think we need to do more work to build resilience for them going forward, and it reflects my earlier point about people, or few people we will inherit, if any, money and legacy issues are some of the risks in relation to this. So there are risks, but are we as well prepared as anywhere else in the country? I think we are, and there are some debates going on about nationally how they might want to support South London, given the good progress that we put in place to get into a good place to deliver this delegation come April.
Thank you. Any further questions? Okay, thanks. So can I just have a show of hands, please, if we're content to approve the PDAF submission to NHSE London? Thank you. Okay, item 7, virtual wards business case. Could I ask Martin to join us? Welcome, Martin. So Martin, floor is yours.
Thank you, Chair. Assuming everyone's had a chance to read the paper, just to give a quick summary. Last year in the planning guidance, each ICS was asked to set up virtual wards to support acute flow particularly over the winter, but over the course of the next 2 years. By December 23, we're to have 40 to 50 beds per 100,000 set up. We already have 6 boroughs covered by local virtual wards, which was set up in during COVID. And we've developed a model of care across southwest London, which builds on those local virtual wards and puts in place a remote monitoring hub. This is to support people for 24/7 care, and that will enable us to bring people who have high acuity into the community and support flow through acutes. So we aim to have 220 beds in place by Q4 this year, and taking that up to 424 beds by December next year. The funding model for that is 4.5 million for 23-24, and 6 million for 22-23, and 6 million for 23-24. It has been reduced this year by $500,000 to fund pay rise, so you'll see a reduction of the original allocation. And from beyond that, this will need to be self-funding. So in terms of a model of care, we need to be able to demonstrate that this delivers for the system over the course of the next 6 to 12 months, I think, to make that case for 24 onwards. So this model of care and this proposal for allocation has received support across the system, so we've taken it to each place. Actually, each place has been instrumental in the development of this and the model of care, and I think what we've got here is a very innovative model. It's been supported by the APC. It's also been supported by SMT and the Finance and Performance Group. We had to do a national submission on our plans for virtual wards, and we got praise from the national team on this model of care and our implementation plans. So the recommendation is for the board to approve this proposal and for the financial allocations of the virtual ward programme. Happy to take questions.
Thank you, Martin. Any questions? Ruth.
Thank you. And I know we all welcome this. We all understand that where appropriate, the best bed for a person to be in needs support is their own bed. So this makes absolute sense. I'm just worried about the impact, particularly the financial impact it's going to have on the wider system. So clearly there is a drive here to ensure that people don't have to go into hospital unless they absolutely need it or are able to get out quicker. I'm not clear how this is going to help with preventing admissions, but more importantly, what support there is going to be for social care, for the voluntary community sector, who clearly are going to have to be able to step up to ensure this works properly. So I'd just like to understand how the money is going to flow and how that support will be available.
So this model that's being funded nationally is to support earlier discharge from hospital, so to reduce the length of stay, and the intention of that is to enable better flow through acutes. What we're creating here is a bigger sort of capability that we could certainly look at how we prevent admissions and work with social care, but the funding's directed towards that means of reducing length of stay in acutes at this point in time. So it doesn't fund social care directly, but the models of care will be working. The local virtual wards will be working with local authorities around how packages potentially could support some people who go through this model, but most people will be probably those who would be going home in the next few days, but would go home about 3 days earlier.
Can I come back to you? So I understand that side of the equation, but then when people are discharged and are at home in a virtual ward, there is going to be a greater need within the community for community care, social care, and support from the voluntary community sector. How's that going to work?
So there's a significant part of this resource goes to those local virtual wards. So there's a significant increase in community teams to be able to support people in their own home who need hands-on care.
Sarah?
I just wonder if I come back on that. I wonder, Martin, if, because I think there's an assumption that there isn't a significant impact on social care. If anything, it'll probably help social care because these people may have been funded by social care if they weren't going into a virtual ward. But perhaps as part of the assessment, because we're going to do an 18-month assessment of this, we could pick that up, Ruth. We could assess whether or not we think there is any impact on local authorities, voluntary sector or others. So we could pick that up as part of the assessment.
Thank you. Dick?
Thanks, Ruth. Just to echo that last point, I'm sure that when we get this, well, let me roll back. This is a wonderful initiative and it seems really valuable to take forward. Let's hope it works and can be scaled up. Firstly, I'm sure that when we get, if scaling up is possible, we do want to look at the finances in the round. And actually, that's probably a good principle for this board, that we should be thinking about the pound we spend on the health of people in South West London rather than the institution it comes from. And the more that can be built in, the better. The thing I wanted to ask about was whether, Martin, you could just give a bit of a more sense of scale to help me imagine what this pilot does. I mean, up to 400 beds in year 2. But it looks like it's about 4 beds of virtual addresses, 1 acute bed. Is that right? And how many acute beds are there in South West London? I'm sure I should know, but I don't. I just want to get a sense of what percentage of the system is this, and what percentage might it be if it turns out to be a viable and strong idea?
So the projections are based around 2 individuals per month going into a virtual ward bed. So a length of stay on a virtual ward for about 15 days. So I guess calculating that out, you're probably talking about, when we've got up to, 424, so in the region of 850 to 850 people per month going through this. Apologies, I don't know how many acute beds there are. I'm sure Jonathan might be able to help with that.
Jonathan?
Thank you very much, Ruth. So I'm going to answer your question. It's actually in the papers, but I also wanted to say, just as I got the floor, as it were, how important this is for the whole delivery of urgent emergency care for this winter. It is a key plank of what we're trying to put in place and have invested in significantly. I was very struck, a number of us were at Croydon a few weeks ago in response to Ruth's question, just to how close working was with local authority and how willing people were to learn, talking to frontline people driving this work, how it was very much seeing a sort of a learning model and an evolving model over time. And I was very pleased to hear we've already got 95 of those beds in situ, so it's good progress. Anyway, to answer your question specifically, at the risk of being slightly over-precise, Chair, but as it's in the papers for the meeting, so it says as of the summer months, it's just over 2,200 beds. It's 2,271 is the number in the paper, and the proposal is there's 2,428 by midwinter, being, as I say, probably slightly overly precise, but between 2,200 and 2,500, I think is the answer to your question, Dick, depending on the time of year.
Thank you, Matthew.
Yeah, thanks, Ruth. So I have the joy of being the SRO for the virtual ward rollout across South West London, and I'd endorse the comment Jonathan just made about the working approach between colleagues to try and get this off the ground. In answer to Ruth's question, I thought I'd just add my perspective, because I absolutely understand Ruth's nervousness with this. I think success of virtual ward would be to make sure that there isn't a social care impact on the basis that these are patients who are supposed to be having a shorter acute length of stay. They're not supposed to be patients in the virtual ward who are already at home getting additional support, and neither should they be social care patients or patients who no longer have acute needs, who now need social care needs, going out into the community through a virtual ward pathway. These should be acute patients who currently are in hospital for, let's say, 10 days, who in the future could be in hospital for 7 days on their acute pathway. And that for me is success. So I think Sarah's right, we should evaluate it, and you're right to raise the issue because it is a live concern, and I appreciate it. But success would be actually addressing your issue by ensuring the patients that are in the virtual ward are acute patients going home early. That requires some system and process. It requires some technology to support it, but most importantly, it requires a bit of a culture change in terms of how we manage, as an NHS, those patients. And that comes down to clinicians being confident and comfortable that the service that they can receive virtually is as safe and appropriate as that they would get for their patients in an acute hospital bed. So that's the work we're trying to do. So I think you're right to flag, but we are very mindful that success of this would be in the way I've described, in which case I think that mitigates largely the concern you have. Admittedly, we should review to make sure that actually what does happen.
Jacqueline.
Thank you very much, and equally as welcomed. So really pleased to see there's a central remote monitoring hub. I think that's great. But my main question sort of links into something Matthew said is, how do we make sure that we standardise and reduce variation across South West London so we don't have 6 different ways of doing things, which is a potential possibility, or at least 4 anyway. And the other question was that I didn't quite understand is you said, and then it needs to be self-funding. What does that, I don't understand what that means and where we might get the funding from if it's not centrally. Because for me that means we might have to shut beds, which seems to defeat the object a bit, but I just wonder what self-funding meant for us going forward.
So the 2-year funding we have is SDF funding, and beyond that we'll need to make the case for how we build this into our baseline costs going forward. So through this 2-year period we do need to demonstrate that this has a significant impact on the system to be able to do that, and make a call probably within the first 12 months around whether it does make a significant impact.
And the standardisation of
So we have got documented SOPs for working with each local virtual ward. The way the local virtual wards are set up do slightly vary at this point in time, but that's okay, I think, because this is at the beginning of a journey. We have got really good working collaborative processes. So I think we've got an opportunity to, as this grows, to be able to come together and have a standardised practice where we can demonstrate how this works well. So we have a monthly CQI process where we look at how it's worked last month and get, as a team across South West London, review that and look for improvement. So I suspect that gives us an opportunity to be able to converge on how we have standardised practice. And this is a scale model. This lends itself to sort of the single way of doing things. But the starting point has been quite different. Each local virtual ward has had a very different model of care. So we don't want to trash that. We want to build on that. So over the course of the next 12 months, we'll have to look at how we do that.
Thank you. And I suppose I just wanted us to note that there are probably some choices to make then for the ICB, won't there, going forward? And that was really good. Thank you very much.
Thanks. Sarah, I think you want to come
Yeah, so I mean, I was going to say the same thing. The thing is that we know for sure that if this works, it will help our hospitals, but it certainly won't empty the hospitals, and it won't allow us to, it will probably just allow us to manage in a better way. It won't be able to reduce the number of beds and so on, because we know that the rate we're running at currently. Therefore, when we're talking about the money, I think we will come to a point where either we will have to make an argument nationally that this should be funded because it's the right thing to do, or we're going to have to take a risk-based approach to saying we're not going to fund something else and we're going to fund this instead. And that's the difficulty that we're going to have as a board and as organisations across South West London. But I think it's worth us being really clear about that. This is nationally funded at the moment for the next 2 years.
Thank you. So we've got 3 more questions that I'm going to take. So Mercy, Karen, then Dagmar.
Thanks. I was just wondering about the monitoring and review. So presumably you're looking at readmittance rates, readmittance if that happens, and maybe the impact on family or people alone at home, just to get a kind of a feel of that that difference and what families are doing really to support that?
Yeah, so as I said, we are looking at, we have set up a CQI process. I mean, bearing in mind this new model is not going to be in place till the end of November, where we'll have the remote monitoring hub operating with the 4 local virtual wards. The 4 local virtual wards are ramping up right now, so capacity on the ground is increasing, but the remote monitoring hub won't be in action until the end of next month. We've set up a CQI process where we review data, and readmission rate would be, I mean, sometimes it's appropriate, readmission, and sometimes it's not. So we'll be looking at that information as we go through on a monthly basis to understand if we could have done things better, and to build that into our processes.
Martin, could I just ask you to explain what the CQI is?
A continuous quality improvement, apologies.
Thank you.
Thank you, Martin. Given the conversation, given the fact that this will be a requirement of self-funding as we go forward, do you want to just give us a view or give us some thoughts on the evaluative criteria, and if you haven't yet looked at that, how you'll develop those so that we can get to a point where we can evaluate the success of virtual wards?
Yeah, on the evaluation criteria, so looking at how the usage of it, I guess, is really important. Are we getting the throughput through this? Because I think one of the key things around this is convincing clinical staff, particularly acute consultants, to utilise the service. So usage will be one of the key areas, readmission rates particularly, experience of the individuals, so feedback from patients who go through this is also going to be key. And, you know, looking at sort of call rates, escalations, how well escalations went, etc. So following through the SOPs, you know, data that details how effective the SOPs were. SOPs? Oh, so standard operating procedures, apologies. So evaluating those, see how effective they were. So there's a number of criteria that actually most of us created, and we're looking at how we collect that.
Will you also be looking at the impact on the acute sector?
Oh yeah, absolutely. So understanding sort of if we're seeing a reduction in length of stay, particularly for these cohorts that we're targeting. So the key sort of specialties we're starting with frailty and respiratory, and then we're looking at heart failure and other gastroenterology and other illnesses. So looking at admissions and whether those admissions we're seeing reduced length of stay is another key, and that will be actually critical in improving the case going forward.
Thanks, Dagmar.
Hi, thanks very much, and as everybody said, in principle, absolutely what we want. I wanted to understand a little bit more about public and patient engagement in the wider sense, because actually, you know, these are really sick patients that stay at home. That is quite stressful and scary. And the idea that the people surrounding these sick people think, oh my God, they're not in the right place, they're not cared for properly. I do feel we haven't had enough of that conversation with the public and patients, particularly with our diverse communities as well. Yeah, other languages, other expectations. So I think that needs to be part and parcel of the pilot, and I would think it lends itself to really be strengthened a bit in the evaluation. Thank you.
Thank you. One of the areas we're looking at is digital exclusion, and so looking at those communities that might typically be affected by this, and looking at whether we're getting admissions through the virtual wards from those communities, so we can understand if we're having an impact in those communities. We have done some engagement, and this model of care has been running for some time in a number of areas. In Croydon particularly, this model is in place, and we've got, I was at the HET conference, which is an IT conference 2 weeks ago, and there was patients from Croydon talking publicly about the fantastic experience they had on this. So I think it's really powerful. The other thing I would add to that is the fact that we've got a 24/7 remote monitoring hub. So you've got a nurse on the phone 24/7 will provide a lot of confidence, both to clinicians but particularly to the individual patient. So I think, and they will be able to ring and check if they're okay. They'll be able to detect if someone's anxious and put extra support in for them.
Thank you. So I think the majority... Oh, Matthew.
Yeah, sorry, Ruth, I should have perhaps added when I was talking before, we actually have the steering group today on this, and I'll definitely reflect some of these comments into that so people have got it in their head straight away. But we are working through the sort of practical go-live aspects now. 28th of November still the date that we're working to, likely to be slightly phased in terms of time during the day. So Martin's just referenced 24 hours. That is where we're going to go as quickly as possible, but we're likely to start to build that from a 12 to 16-hour start, just in terms of testing how this is working, what's some of the challenges, etc. Bear in mind this is quite a different thing, and I thought for completeness we should probably just note that to the board.
Thank you, Matthew, and I think it's good if you could take the sense of the discussion that we've had today back to that board. So I think there's three main aspects that we've reflected on. The importance of the impact assessment, and ensuring that in doing that we understand the impacts on partners across the system. Secondly, that needs to inform a set of choices for the ICB in terms of funding of this once the NHS funding is finished. And then I think we've had a really good discussion about the culture change, both in the sense of practitioners and clinicians and their understanding of how this can benefit, but also in terms of patients and service users and thinking about exclusion and hard-to-reach communities. So I'd be grateful if you could reflect that, Matthew and Martin, in terms of how we take this forward. On the basis of that, is the board happy to approve the business case, and could I have a show of hands, please? Thank you. Moving on then to item 8, which is the board assurance framework. So could I ask Ben to speak to this item, please?
Thank you, Chair. So this is the first time that we have brought the board assurance framework, the BAF, to the board. The BAF usually comes twice a year to the board in September and March. And I think it's just worth noting that the BAF is a living document that we're continuing to develop as the organisation itself develops. So the purpose of BAF is to inform the board of our highest scoring risks that could affect the achievement of our corporate objectives. Our risk reporting cycle around this runs on a 2-monthly basis, and as well as the board assurance framework which reflects those highest scoring risks, we also have a more detailed corporate risk register that sits behind this. So over the coming months, we will continue to develop, evolve and review both the BAF and our corporate risk register to ensure that we are capturing and reflecting the risks that are facing the organisation, and that we're doing that accurately and appropriately. I won't go through the actual paper in detail, Chair. I presume people have read that. But as you can see, at this point in the development of the BAF, there are 6 risks which score over 15, and we've got 1 risk that is just below 15, as detailed in the paper. I'm very happy to take questions, and my colleagues around the table will be able to comment on specific risks if they wish to.
Thank you. So Sarah first.
Yeah, can I just say, I think it's important to remember that this is a new organisation. First time we've seen the board assurance framework. We will need to do some work together, I think, as a board to ensure that we feel that the board assurance framework reflects our high priorities and risks as a board that and that we're all signed up to that. So as part of our organisational development framework, I think we might need to pick up some work on this. So we have inherited some risks from the old CCG and other parts of the system. So it is a piece of work in development rather than a fully formed board assurance framework.
Thank you, Sarah. Any other? Jacqueline?
So I suppose I get a bit concerned that the quality risk is lowest than anybody else. So you would hope that. But given when you look at some of the risks we've got, so access to emergency care, we know there is evidence that actually patients are coming to harm because of either ambulance delays or delays in the ED department getting into a bed. So we know that already, so that is right. But it's the bit for me is how does it then link into the quality bit? Because quality per se is one thing, but it does link into that and the money, actually. So I suppose I'm questioning that score, and I know this is a new thing and we're feeling our way, but how we link it all in so that it's not all done separately. Because for me, quality is a really high risk at the moment for all the reasons I've just said. And I know looking at Vanessa, she'd say, and then we've got mental health and Dan. So for me, I think we probably just need to rethink that one in light of some of the other risks.
Thank you, Jackie. I'm just going to ask Gloria to briefly come back to you on that.
So, Jackie, I totally agree with you. And I think that's some of the things we might want to work on going forward, that each of the risks should actually identify where quality is being imparted. And that will be incorporated into everything we do. I totally agree that we shouldn't be separating it. But the quality risk we have there is about developing quality at place and that transition bit. And that's why the scoring is lower. But I think some of the things you raise in terms of UAC, delays, and so on and so forth, there is definitely quality impact in almost every risk, and that should identify all the risk.
So I asked that actually the quality risk we've got, I think it needs to be bigger in what we just talked about at place, actually, because we're interested in the quality wherever it's patients looked after. So just to thank you.
Thank you. And Sarah,
I think that's exactly the point I was making, that I think we need as a board to identify what we want in our board assurance framework, which might not just be an escalation of risks, but actually our high priorities and how we perceive the risks in the system. And I do think that might be an OD for us as a board to do going forwards. And we have inherited some of it as well, the actual risks and the way they're written, but I definitely think there's room for us to change that.
Vanessa.
So 2 points. The risk in connection to mental health, I'd really like to work on through the partnership delivery group that we've set up, so be really happy to contribute with that and to get that risk into, because I think it is broader than just our emergency departments, it's across the board, but it's helpful to at least have a placeholder here. And then the second was a question as a place convener, which is we're doing work at our place on our effectively the executive risk registers, and it's how that then feeds into the board assurance framework up and down, isn't it? And I think it would be useful to have some timelines from you, Ben, about actually when would you like us to produce our place risk registers in order to then be able to feed into this piece of work, so that it's a much more collaborative piece of work. But thank you.
Thank you, Vanessa. I'm just going to ask James to ask his question, and then do you want to come in again? Yes. Yeah, and then I'll ask Ben to respond.
Thanks very much. So I was pleased to see the risk around failure to modernise and fully utilise our estates on the board assurance framework, but actually going through it in detail, it felt a little bit narrow in terms of it mainly focused around voids and specifically QMH. For me, actually, our risk around estates is much, much broader than that, and I wondered if we could look at broadening the risk and articulating a slightly wider set of controls as well, particularly given some of the wider economic challenges in the capital environment at the moment.
Sarah.
Also, I think we just need to work out ourselves how are we going to do this as a system, because what we're not, we don't want to reflect every provider's risk on our risk register. So what is it that as a ICB are our risks, and how do we reflect those in a way that we're not cutting across individual organisational statutory responsibility, but we take account of the kind of oversight function of the ICB. So it's new and different, I think, and I think that's kind of reflected in where we are and where we need to be. So just for some thinking for people.
Thanks. Ben, can I ask you to come back on those questions, please?
Yes, so certainly. So I think to Jacqueline's point, I think Gloria's picked up and we'll work on that broader risk for the next round. Mental health ones, absolutely. Vanessa, and we've been working with Tonya as well, and Mosa will link in with yourself and through that route. The team have started to talk to place teams about how we do that risk reporting from place. So absolutely, and it would be great to work with you on that. And to the estates points, James, Helen and I have been talking a lot about that risk over the last few weeks as well. So yes, absolutely, we'll feed that into the review process for the next round.
Thank you. So what I'm going to ask the board to do is approve the board assurance framework, but on the basis that we need to do some further work as a board, and in particular broadening out the risk on estates, thinking about how the work at place on risk will feed into this process, the interplay of the risks and their impact on the quality risk, and that we probably need to spend some time as a board working through these issues. But on the basis of what we have here, we approve for further work. Are people content to do that? Yes. Yep. Thank you. So moving on to item 9, which is the ICP update. So if I could ask Ruth to come in, please.
Thank you, and thanks for this opportunity. I think it's really important that we have this way of working across both the board and the partnership, so I really welcome the fact that this is now an item on the agenda. We've now had the second meeting with the partnership. There's a real sense of purpose and determination to make this work, but also I think a growing recognition of just how complex the system is, which doesn't mean we're not going to, we are most definitely going to get through it, but it is extremely complicated. Each borough, as you know, has a place board, has a health and wellbeing board, has a lot of people working very hard within the local communities to achieve the best possible outcomes for our residents. And to bring this together into one place and to talk about the overarching principles that should be governing us all is complicated, but if we get it right, my goodness, it could make a real difference. The driver for this has to be about health inequalities, recognising that over decades, I would argue, we haven't really managed to address those terrible health, social, economic inequalities that exist within our boroughs. There are huge areas of deprivation within our 6 boroughs, and in spite of the reputation that South West London has with the rest of London to be a relatively affluent and leafy place, we all know that isn't true, and there are people that are really struggling. And if I think about what's happening at the moment, where we know that children are coming to school hungry, where each borough is having to set up a warm centre in order that people can have a safe and warm place, so they can not have to turn on the heating at home, and to hear conversations where people are telling us that they cannot afford to heat their homes or else provide decent meals for their children, and asking us desperately for advice. It really gives a sense of the urgency. And I think the thing that underpins this for me is the risk that we are so focused on the immediate and the immediate emergency, which is real over the winter, that we take away the focus from the long term, and the long term has to be about prevention, early intervention. We heard Vanessa at the last meeting that a lot of issues around mental health happen by the age of 13, 14. It's true of mental health, it's true of physical health as well. So we're going to have to somehow bring together the need for urgency to help people get through this winter with the increasing constraints on our funding. We all know that the financial situation for all of us is dire, and yet the need is increasing. So it is important, I think, that while we bring together an understanding of what's happening across the wider place, across our 6 boroughs, we also get better at focusing where the priorities are and what is going to make a difference. And I think that is very much the role of the partnership, which can then help to influence the work that we're doing here on the board. I think there's a real potential here. As I said, all the partners are up for this, looking specifically at Simon Breeze, representing the voluntary community sector, but talking to community pharmacists, talking to the wider system. Everyone recognises that things have to change. And the way it has to change is that we work differently and better together. We do need to focus on the immediate, as I say, the winter crisis, and interestingly, the next item is exactly on that. But we need to carry on thinking about what will actually make a difference long term and mean that people won't need to access those acute services later on in life. So there's a lot of work to do, but I am feeling very positive. There's quite a bit of governance going on at the moment, but that's important too, because we need to understand how all the bits fit together. And I look forward to giving an update at the next meeting. Thank you.
Thanks, Ruth, and I think it's really important that we understand the interplay between the 2 committees. So these are really key for the Integrated Care Board. Any questions for Ruth? Sarah?
I thought it was just important to state that obviously the Integrated Care Partnership will be developing the strategy for the next 5 years, of which we will, as an ICB and local authorities, will need to respond when those priorities are set by the ICP, we will need to feed that into our delivery plans as we go forward. And I do think that's really important. There's a real opportunity there for us across NHS, local authorities and partners to really make a difference. We've got to go through the process to identify those priorities, but I think there's a real opportunity there for all of us.
Thank you. I'll just ask Matthew and Dick, and then Ruth, I'll give you the opportunity to respond.
Yeah, I was just thinking about the description Ruth gave and the previous conversation we had on risk and Sarah's point about what are the ICB risks as opposed to statutory agency risks. I haven't quite formed it in my head, but there's something out from what Ruth has just described that probably, having looked at what we've put as our ICB risks, that we could also add in to respond and ensure that we're sort of focused on that aspect of our work, as opposed to the ICB risks just being a system version of what we've all got in our own risk registers as a statutory organisation. So it's not a fully formed thought, but I think it's worth raising and might help us a little bit to capture some of the things that Ruth was saying.
Thank you, Ruth. I just want to go back to Ruth Dombey's point about priorities, because it does strike me as the strategy is developed and discussed, there's a risk of seeing all the things we'd ideally like to do, but we live in a very non-ideal world with all sorts of problems sort of get in the way. And the more we can think about obstacles and the ways in which the different organisations that make up the partnership can survive helping the collective outcomes we're searching for, and being quite hard-headed about that, I suspect that will increase the chances of us developing a really powerful strategy that has traction and gets real commitment that organisations know they can viably keep pushing for over the sort of timescale we need to address some of these big shifts in the sort of inequalities that you were describing, Ruth. So I wonder if we can find a place for obstacles and challenges, the difficult bit, as well as the aspiration, to help us be more realistic and effective in developing a strategy.
I think Mercy wants to come in, and then Ruth, I'll come back to you.
Yeah, it's really just more of a comment. I think why the integrated care system is being set up is to look at prevention and health inequalities. And so it is about us, as an IC board and an IC partnership, getting that balance right. So I think that is our biggest challenge, as Matthew and Dick has been saying, looking at kind of risk and looking at priorities. But I think if we don't get that right, then we wouldn't have done our job.
Thank you, Ruth.
Thank you, and I agree with all of that. As we go forward with the work of the board, I'd like to see a greater understanding of the impact on the system of the decisions that we're taking here. I recognise this is an NHS board. I recognise that what we're doing is relatively constrained. But if we're talking about discharge to assess, if we're talking about virtual wards, these are all decisions and pieces of work that have an impact on the wider community and on all the partners. And I really think it's important within the work that we're doing in the board that we recognise that. The point you made, Dagmar, about also ensuring that our communities understand what we're doing is absolutely important as well. And I think the partnership has an important role to play in helping with that too. Thank you.
Thank you, Ruth, and I think we all agree with that sentiment in terms of the decisions that we take here. So is everybody content to note the report? Thank you. Moving on to item 10, winter preparedness. So can I ask Matthew and Jonathan to speak to this item?
Okay, thank you very much, Ruth. I think I'm starting this, so thank you very much, Ruth. So we did have some conversation about this last month, given the importance of winter. So colleagues will have seen much of what's set out here before. But to give a very brief summary, there are 8 areas that have been determined nationally. It's really important for us to focus on to address the immense pressures that Ruth has already talked about a little earlier, and we all recognise in the system at the moment. And just There's details in the papers on each, but just to mention them, they are immunisations, that's including things like COVID and flu vaccinations, primary care and capacity in primary care for this winter, how 111 and 999 services are going to support us through this period, a specific ask around category 2, so that's for patients with stroke, for example, and how we ensure effective ambulance response times for those sorts of patients, how we reduce crowding in emergency departments across South West London, hospital occupancy, which we've already touched on through some of the work around the virtual ward, linked also to timely discharge, and the 8th area being for support for people living in their own homes. As I said, we spent some time on that this morning with the conversation about virtual ward. In addition to those 8 priorities, when we were thinking about this in early summer, we felt there were 5 other areas that felt really important to us in South West London. So the first was mental health, so there's a particular focus on that. There was another piece around how we manage winter surge and winter pressures and emergency preparedness, so there's some information on that. Workforce, supporting our workforce given all the immense pressures and challenges felt like a really important area to touch upon. How we communicate with the local population, and also, as we've also just been talking about, linked to the board assurance framework, quality and patient safety and the work Gloria, John and others are doing with medical director, nursing director colleagues across the patch in relation to reflecting on the impact of people having long lengths of time in emergency departments and to access care. And the reason we pushed on at pace with that through the summer was there was just over £13 million worth of resources allocated to South West London by NHS England, and we made the decision, as has been reported earlier in this meeting last month, to allow maximum time for people to secure the staff they need and to put services in place. We made the decision about how that was going to be invested last month. The paper sets out the detail of that. It describes how we'll put the equivalent of 157 additional beds in the system to support people through this winter, and there's almost 20 individual schemes set out in the slide that describe how we draw together to that total of additional beds and additional capacity at this point in time. So that's probably all I wanted to say, other than probably just to pick up also on Ruth's point about forward thinking. So we are trying to do that in this space. So 60 or 70 people across the system met on the 8th of July to think about what we could do to support care this winter across the system. And then we reconvened a couple of weeks ago on the 30th of September. All the local authorities were there, and other partners across the system, to talk about what could we do to move to a more sustainable model version of emergency care over the next 5-year period. So at a point in time, that might be something that we want to think about how we play that back here. But I thought the point was well made about it's both what we need to do to manage the short term and the immense pressures faced at the moment, but also think a little further ahead about how to support the system going forward. So that is the other element I probably want to call out. So that's probably all I wanted to say. I'll ask my co-SRO, Matthew, whether you have anything you'd like to add.
Yeah, thanks, Jonathan. Just a couple of points, Ruth, if I can, because I endorse what Jonathan said. I mean, we've got a lot of work in play already, which is a good thing, and many of those schemes are up running and are full already. And that's positive in that we've cracked on, but it does mean that the challenges that we're still to face are likely to require more than we have in play at this moment. I was on call yesterday, I've been in my ED this morning, and it feels pretty much like midwinter already, and of course it's not. It's still sunshiny outside at this point. So I think we have to be clear with the board that there is definitely more work to be done for this winter. That is not to denigrate any of the work that's been done thus far by anybody. All partners are involved in that right across South West London, and each of the NE delivery boards I chair, mine in Croydon, but we have a South West London infrastructure, and there's definite, commitment and a good deal of experience in running the winter and emergency response more generally. I would say the impact on patients and staff shouldn't be underestimated. I think Jacqueline makes a very important point about the risk register and the BAF. Certainly from a patient's perspective, waits are too long, and that's not what we want. There's understandable reasons for that, but that doesn't take away from the plain fact that there are patients waiting too long in all aspects of our service at the moment, and I think that's also important to just flag that this isn't just, sometimes it's easy to think it's ambulances or it's A&E or this is a whole pathway issue, including primary care, but also including community services, acute services and social care as well. So shouldn't ignore that impact on patients or indeed staff, and I think one of our key responsibilities, obviously individual organisations, but also as a sort of the leadership of South West London, we need to make sure that we're using our powers to support those staff, to engage with those staff, and to give them reassurance that we are continuing to do work on this, and most importantly for the patients, that they know that that is also our objective for this winter. So I don't think this is going to be an easy period. I think there's going to be some real challenges during this time, and that's stating the very obvious, but I think worth saying and noting here at the board, and that we're not underestimating the challenge, but also we've got a lot in play at the moment, more to come, and we'll continue to support everybody in that endeavour.
Thank you, Jonathan and Matthew. Can I take questions, please, from the board?
Yeah, I just think we ought to have a discussion about this. I think this is one of our biggest risks, actually, and it's for the whole system. It's not just for the NHS, particularly with we've talked about the risks spread across the system. Often the risk is not to the people that are in hospital, but it's the people that are not yet in hospital but actually can't get into hospital because they are still out in the community and we can't get ambulances to them and so on. So I do think, I wondered how much we've thought about the risk-based approach and how we actually think about risk differently. I know that Jacqueline has raised this with us previously, how we think about risk across the system in a different way, because we do tend to focus on what's in hospital rather than what's outside of hospital. And I just wondered if you could tell us a little bit about that.
Can I add to that as well, about the workforce risks, which I know have been flagged in this report, and I think Matthew, quite rightly, you've talked about the impact on both patients but also staff across the system, and I'd just really welcome a bit more information about how those risks are being managed from a workforce perspective through the group that you're working with.
So I'll start on both and then Jonathan can add. I mean, in terms of how we try and manage risk across the system, I mean, that is not straightforward, because there will be some aspects of that that we won't know about as easily as others. You know, some of it you can see it's right in your face, and that's sometimes the area, therefore, that you put the effort into. The short answer is the A&E delivery boards that exist, terrible title, I should say, because they're not actually about A&E, but that is the nomenclature that we're encouraged strongly to use, so that's what we're using. But those urgent and emergency care conversations have all partners in, and LAS, for example, in our sessions in Croydon, and I'm sure it's replicated across the piece, are raising the issues of the patients that are in the stack, to use a whole bit of jargon, but the list of patients who are waiting to be picked up by an ambulance, because those are some of the patients that we're less cited on and are less obvious. So the A&E delivery boards is the mechanism by which those risk conversations should be taking place on a monthly basis. Now, obviously on a daily basis, we're looking at trying to operationalise that, and there's all sorts of initiatives that are now being developed. Jacqueline might want to talk about the North Bristol model, for example, which they're piloting in as parts of her patch, which is to try and say, okay, well, if we've got real pressures in the whole system, how might we spread some of that in a way that we haven't before, by increasing numbers of patients on wards to allow patients to be offloaded in from ambulances, which consequently allows patients who are currently just people out in the community to be picked up by the ambulance and speed that process up. Now, that is not without its challenge, it's not without its risks. There is a discussion about how that risk is balanced, but it's an active conversation that I know Jacqueline's team are on, and we're starting to look at our version of that. And we were at a Chief Exec's meeting on Thursday last week, where nationally that was being encouraged to be assessed. So it's those sorts of things, I'd say, from how we try and manage risk that we can easily see, and risks that perhaps are slightly less obvious from a patient and the population's perspective. In terms of workforce, I mean, if we had an easy answer to that question, then we'd be very, very popular, because everybody is struggling on that in all parts of the system. You know, I was talking to my GP colleagues at the end of last week. They're experiencing it, social care is experiencing it. We've seen the numbers of social care staff dropping down a little bit nationally. Certainly the pressures in my own organisation are as acute as anybody else's. So the issue is very clear. I think the immediate thing we can do is to support our staff the best way we possibly can, because we are not going to magic wonder solution on workforce for this winter. There are things that we can do and be a little bit flexible about those in terms of how we recruit and crucially retain our staff. But at the moment, our focus has to be on supporting the staff that we have in play and trying to make their day-to-day experience as good as it can be, and in parallel then do work on, so what does the future look like? And that, I think, from my perspective, needs to include a whole load of different things like apprenticeships and building on that, and about bringing in a different type of workforce, and rather than just keeping going with what we're doing and backfilling the gaps we've got with locum, agency, overseas recruits, etc., all of which have a place, but we have a big workforce in our local patch that we could probably do a darn sight better for them and for us by accessing. And I think that's probably the area that I'd say we need to push on. But is that going to solve my challenge on workforce in 6 weeks' time? No, it's not. The thing that's going to do that is my staff feeling like they're supported and engaged, and that they've got a level of control in what feels like at times a very uncontrollable situation. So that's me being very straight and honest with.
Thank you, Matthew. Jonathan.
Just to sort of add to what Matthew's saying, around risk, I think it's a really interesting point that Sarah's raising. We have set up a clinical forum that works with the Urgent Emergency Care Board across primary and secondary care to talk about clinical risk. But it's a complex area given given the clinician's responsibility to the patient sat in front of them versus the people they probably don't know who are out there in the community who do need access to care. But we are trying, Matthew and I are trying to sort of formalise that group and try and get some clearer outputs about how we might support the management of clinical risk. I think it's vital to the conversation we had about virtual wards earlier, that there's some collective agreement between secondary and primary care about the cohorts of patients, their complexity and how they are managed across. So I just wanted to sort of say under the auspices of the Urgent Emergency Care Programme that work is in train. And also on workforce, to that reset event I was mentioning earlier on the 30th of September, there was some thinking that emerged out of that. There are things we can do. Perhaps some of the flexible contracting arrangements might be an area we want to explore across all our organisations to optimise how we make the most of the sort of 60,000 people who work in the NHS in South West London. So, but as Matthew also says, it's not going to fix it for this winter, Ruth. This is a long challenge that we face, and I think we all recognise that. But on both points, we are focused and energised.
Important, thank you. Dagmar.
Yeah, I just wanted to come back to workforce. Absolutely, I mean, that spans the whole system. So keeping the current workforce healthy is just one aspect, and obviously vaccination, everybody's tired of even thinking, hearing it, but it is so important, and we haven't exactly got a run-in for the autumn booster or the flu, particularly from staff. So again, sharing and reinvigorating. I haven't got recipes up my sleeve, but that is certainly something concrete that is within our gift. The other thing is around mental health and burnout. So the remaining staff facing that winter, thinking, how on earth am I coping? Just thinking a bit more now about that. these are the two things. Thanks.
Thank you. I'm going to ask John and then Vanessa to come in, and then I'll go back to Jonathan and Matthew.
So it's really important that we talk about the workforce. I was just going to digress a little bit into mental health and see that it's good to see that's one of the key priorities and area of focus. There is obviously investment going into mental health in terms of the block purchase of bed and some pathway redesign. Can I just ask Vanessa, in the sense of...
Apologies. Do I need to start again, or do you think? Okay. So, just in terms of the mental health block purchase of beds, bearing in mind Claire Murdoch's letter about quality of care and restrictive practices, is there anything more that we need to do in terms of assuring ourselves that if and when patients do go out of area, that the same standards of care which would be applied either with yourselves or SLAM are being applied in the independent sector?
So I don't think investment is being made into the block purchase of beds. That's coming at an overspend to the Mental Health Trust, just so we're clear, but it's the right thing to do. The reason we've decided to go through a block purchase is in order to secure beds as close to home as possible, and to ensure that we can access beds with the appropriate CQC rating, etc. We ensure through our bed management system that every patient who's placed in the private sector has robust follow-up, and that we maintain contact with their families, etc., and that the quality standards are met wherever possible. It always becomes more complex the multiple people that you use. So our idea would be obviously to manage within our existing bed base, or to extend our existing bed base to facilitate care closer to home, and we are working out proposals to do that. I think one of the points from the conversation today is it's not just the number of people, is it? It's the acuity of the presentations. And what I would say in mental health is it's the acuity of the presentation and the level of unwellness when people are requiring the bed that is really the issue. So our average length of stay, which is not a 100% scientific tool, has significantly increased. It's increased by 4 or 5 days, because people are needing longer in order to recover. And if we could get people into us quicker, then the hope is that they wouldn't be in hospital as long, and the restrictive interventions wouldn't be in place. You'll be aware that the Panorama programme focused on long stay, not long stay, but rehabilitation, forensic services. And what we've done is particularly focused on those patients with the most complex of presentations, which tend to evoke very strong reactions between the patient group and the staff group, and how we manage and foster culturally competent and thoughtful conversations. So that would be my response to that. And then in addition, what I would say is we've talked a lot about our paid workforce here, but there is an unpaid workforce in our carers, family and friends, that I think the more that we can do to support the networks that support them, to facilitate resilience this winter, is probably one of the wisest things that we could do, in addition to all the great work that goes on at the emergency care boards.
Thank you. Any responses to those issues?
I mean, I wouldn't disagree with anything that's been said. I think it's important to note the breadth of the points that are being made, and we'll definitely continue that work ourselves in the urgent emergency care work stream. So I wouldn't disagree with the points being made.
Right. Thank you. Sarah, can I just ask, in terms of how as a board we maintain oversight of both the short-term risks that we've talked about in relation to this, but also most importantly, as Ruth has said, keeping an eye on what are the longer-term developments that we need to reflect on as we come out of winter, and thinking about how we address some of those risks that are long-term risks in the system.
So I think we can ask Jonathan and Matthew. As they mentioned, there is some work going on where we did 2 workshops to think about the long-term strategy for urgent and emergency care. I think that should come back to the board with the priorities for that, and make sure that we're all comfortable that is going in the right direction. And we will ensure also that the board receives regular updates throughout the winter on where we are on delivery on a day-to-day basis. So we will make sure, I think, that we bring both items back to a future board. Thank you.
Thank you, Sarah. So on the basis of the discussion that we've had, is the board content to note the report? Thank you. Okay, we now have a short comfort break, so we can take 15 minutes. If I could ask everybody to be back for 11:35, please, and we'll have the Integrated Care Board reports. Thank you. Could everybody take their seats, please? Welcome back, everybody. So we're now going to go on to item 11, which is the Integrated Care Board reports. So at each ICB board meeting, we receive formal reports from the quality, performance and finance functions. The first report is from the quality team and Dr. Gloria Rowland, our Chief Nursing Officer, who will talk us through the report.
Thank you, Ruth. I just want to say we are trying different mechanisms to report in a way that it will be sustained, but actually be more meaningful to the board. But most of the details and the digging down happens at the Quality and Oversight Committee, chaired by Mercy. What we've done this time around is to actually divide it into 4 different areas: under safe, experience, well-led and effective. What I would say is that in terms of the metrics, we do have roughly about 66 quality metrics that we need to report nationally, but we've picked the key important ones. And later on, I'll talk about the dashboard. We've created a quality dashboard in the system, which in a way, apart from the once we report here, if anyone triggers, we will actually then report that upwards. So we are developing a framework to really be able to do that. So I'm not going to talk fully in terms of each of the items here, but I'm just going to pick few of the metrics. So under SAVE, I've picked never event, and I'm not going to say much about never event. There are really 2 things that are really driving our performance there, is in terms of retained foreign objects and wrong side surgery. However, it's just to say when we benchmark ourselves against London, we are actually second best in London. That is not to say I've never event is the right thing to do. However, and I know Mercy did challenge us at the class quality that we should look at the whole of UK. How do we benchmark? So that will be our next work going forward. Also, we've also done a deep dive into what is really driving that for the past 5 years. Again, that report will go through the quality committee and will bring key highlights to this board. And you can see other things like never events and so on and so forth. We've already analyzed them, and what we've done in this report is not to just report the numbers. We've talked about what we want to do, actions and improvements that we want to make in those aspects. Another area that I want to highlight is IPC and COVID. IPC, we were doing well, but we've seen slight increase in like E. coli. But more importantly, in terms of COVID numbers, has actually significantly gone up in the last few weeks. So we've got a few hospital admissions, and we are looking at that closely. That is not translating yet to ITU admission yet, but we are watching closely. And I think some of the hospitals are already stepping out their preventative measures, such as few of them are already using masks in the clinical areas, and we're also probably implementing testing in the areas. So I just want to highlight that. In terms of patient experience, I just want to say there are multiple factors that is driving patient experience. One area that we are looking at is how do we really triangulate safety, experience, and the risk register. What is on the risk? How do we triangulate that? We are purchasing a software called Radar, and that is where all these different reporting is going to be sitting. And that radar system, the work is to help us triangulate and actually bring out key issues early so that we can be more proactive. And I just want to mention that in terms of patient experience. In terms of some of our highlights, in terms of our complaints in the ICS, the main area of focus is around the continuous healthcare. And it's more or less around communication, because it's a very emotive topic, whereby there's financial importance attached to it. So definitely we do get complaints around that in terms of abuse and so on and so forth. And I think finally, I just want to mention we did mention 5 risk areas in our report, and I just want to mention one that we actually debated more at our quality board, and it's to say that our primary care, I think we can actually proudly say we have good understanding primary care system across Southwest London in terms of GP practices. And I've written here roughly almost about 75%, actually very good. But we do have about 12 practices that are rated requires improvement and inadequate. And this is about 6.7% of them. But what we want to do is to strengthen that, just to concentrate on that, to be more proactive, because some of those GP practices have also closed due to quality issues. We want to be proactive so that we don't get to that stage whereby surgeries are closed. While we are doing well, we don't really want any practice to actually be found wanting within the system. So that will be our key focus, really looking at those surgeries that are rated requires improvement and inadequate across the system. I just want to mention that. In terms of some of the developmental work that we are doing in terms of quality oversight, we are continually working with PLACE to develop the PLACE and the PLACE quality framework, and we are meeting with individual PLACE to just agree on how we make sure that we strengthen that and the full implementation of the new framework really go ahead. That I want to mention. And also to say, in terms of urgent and emergency care, and I know Jonathan alluded to that, we are doing some quality work in terms of looking at harm caused by delays. So that work is still progressing, and we are looking at reporting the first lot around January time. And like I said earlier on, we are developing a quality dashboard. We are just at the stage of testing. And hopefully when that is alive, that will be able to help us escalate this easily and help us to be more proactive in terms of dealing with quality issues in the system. And also in terms of our quality strategy is one of the key areas we have to develop. We have done the first draft of the quality strategy. It's gone back to the system for people to just comment, and hopefully we'll be finalizing and going through the quality committee for that to be ratified, and finally here for it to be signed off. At the back of our report is just talking about next steps in terms of some of the things we're going to be doing. And finally, this is just for the board to note and just to say that we are strengthening our collaboration with other partners within the system. I'm happy to take any question.
Thank you, Gloria. Can I bring Mercy in as well, who chairs the committee?
Yeah, I was going to make some comments generally, actually, just about what we're doing on Quality and Oversight Committee, just to reassure the board. Obviously, we've only met a few times, and we look at both quality and performance. I think it's true to say we're finding our feet as a committee, and we've just appointed patient safety reps as well, and they need to join us. I think it's important that as a committee we make sure that we're looking at the whole system and looking at accountability, but that we're not kind of reinventing the wheel and kind of doing kind of double assurance that's already done at provider or place level. I'm quite keen that we don't do that, because it's really a waste of our time, because those assurances at a kind of local provider level are are good, and so we need to use our time most effectively, I think. So we are looking at a range of kind of areas that we've going to explore in more detail. I think that's a better use of the committee, as well as obviously assuring the board, before these reports come to the board, that we've had a kind of a look at them, that we've inquired into them as Gloria says, I challenge some things as well, but obviously having the full board look at them too is good. So I think we're developing. We know that though we've started with a certain legacy, that will change as we kind of develop kind of new systems and ways of working. So I think it's kind of developing that really going forward, and actually working as a full board to think about what they want as assurance at Quality Oversight Committee as well would be really important.
Thank you, Mercy and Gloria. Any questions on the quality report? Jacqueline?
Thank you, Ruth. Just for my understanding, really, so just in terms of the falls at St George's has probably twice, if not 3 times as many beds as other providers. Is that a straight falls or a percentage per bed days? Because if it's a straight falls, we probably would have more falls than everybody else. But just if it's a percentage of bed days, then that's a worry.
So I just need to clarify that I'm not 100% sure whether it's a straight fall or percentage per bed days. But let's find out and I will get back to you around that.
Thank you.
No further questions. So is the board content to note the report? Thank you. Okay, on to the next report, which is the performance report, and Jonathan Bates, our Chief Operating Officer, will talk us through the report.
Thank you very much, Ruth. So, again, hopefully colleagues have had an opportunity to look at this. So if I were to summarise it in a sentence, I think I'd say the pressures are continuing to rise in the system and the performance challenges are increasing, perhaps no surprise in the context of some of the wider issues we face, but I think important to summarise that. There continue to be some highlights and some bright spots. Some of them we've had for a period of time now, but I think they're worth mentioning and calling out to the board. So things like our dementia diagnosis rate, our learning disability health checks, all in a very good place. I'd also note the further inroads we've made since this report was produced in planned care, particularly in the long waiting patient cohorts of 78 weeks and 104 weeks, where we eliminate 104-week waits, and further progress in 52-week wait reductions as well. So real progress at managing care for patients and giving people timely access. That remains a very strong position in comparison with the rest of the capital and nationally. Our challenged areas, well, we talked already about urgent emergency care, and you can see that writ large in this report, with only 3/4 of people getting access to care within the 4-hour national standard, and something like 1,700 people waiting over 12 hours in an emergency department for physical health reasons. I think there's about another 100 patients for mental health reasons as well. And you can also see the challenges that we faced on things like 111 performance with calls abandonment rates and answering not being where we want them to be. And a lot of this driven by flow through the system. You can see that represented by the number of people who were in hospital for longer than they previously would have been, reflecting some of the acuity that colleagues have been talking about earlier, but also some of the capacity issues that I think we face across the whole health and social care system at this point in time. So I say that's writ large in the report, and we did, Chair, spend some time talking about that in the previous item, but I just wanted to call that out. In terms of other areas, cancer, performance, an area where normally South West London does excel, we're starting to see some challenges around particularly achieving the 62-day standard, which is from GP referral to first definitive treatment for patients. To reassure the board, we have recovery plans shared with us, and we're working through those and reviewing those on a weekly basis to see are we moving back towards the trajectories we've set ourselves across South West London. That feels a really important standard, and a lot of it is actually driven by good news story, the good news story being that missing treatments through the pandemic have largely been found, as it were, and people are coming forward for treatment, and that results in, that's obviously a good news story for patients, but does place an additional pressure on the system, and you can see that in a number of specialties at this point in time. So that would probably be my second area. And then the third area of challenge is mental health generally. I think across a whole range of indicators, Vanessa would be much more articulate in describing this than me, but be it inpatient settings, community settings, psychotherapy settings, etc. There are the real challenges we see across workforce and capacity in every other setting equally apply to mental health, and I think that was an important area I'd want to acknowledge. So in summary, those would be my 3 areas of most significant ongoing challenge to us, and again there's quite a lot of detail in the report, and very happy to take any comment or question that colleagues may have. And ideally, I don't know whether Mercy wants to add anything on this before we open it more widely.
Just to reassure the board that we obviously have gone through these figures, and particularly looking at trends and what's happening in the system.
Thank you both. Questions from the board, please. Karen.
Jonathan, obviously we're concerned about the cancer performance, aren't we? In the recovery plans that you've seen and the trajectories that you've seen, what's your kind of assessment as to when that's going to come back in line?
So the commitment we've made is we'll be back on target, our trajectory, by next March. And it's different for different providers. So some are actually in an okay position, but some are much more challenged. There are different, as I say, time frames. There's also complexity. So some of them are specialist national services, like the sarcoma service, which is a particular issue at the Royal Marsden. But a number of trusts face challenges. I think we also have to link this to the overall reduction we've seen in waiting lists is good, but access to diagnostic services and making sure that all the modalities of diagnostic care keep running at maximum capacity through the challenges we face through this winter. So have we in the first week or two seen movement towards the trajectory? Yes, but it is just the first week or two. We need to see that progress ongoing, and of course I'll happily report that back here over the coming months. It feels a really important indicator, and I think that's well recognised, and through close working with Royal Marsden Partners, who are our Cancer Alliance, they are helping us drive forward a lot of this recovery plan as well, so that's great.
Thank you. Any other questions? Thank you both. Is the board content to note the report? Yes. Thank you. And then the final report that we have is from Helen Jameson, the Chief Financial Officer, who will talk us through the finance report.
Thank you, Ruth. So as Gloria described around the quality report, this financial report has been developed and evolved for the board, and so actually any feedback on it and anything you feel that is missing or you would like to be added, please do let us know, because we want to enable to make sure we have the best conversations here possible. So I think it's fair to say the finance report is probably in two parts within this report, and it is quite complicated from that point of view, so I just thought I'd take a bit of a step back and describe the two areas. So as an ICB, we get an allocation of 2.9 billion over a year to be able to support the health of our population within South West London. We spend that 2.9 billion within South West London and beyond, where our population sometimes needs to have care outside of our boundaries. And so that's the key sort of, if you like, internal budget of the ICB as the statutory body that we look at. We then have a responsibility around the whole of the NHS system in South West London, which spends around 4.7 billion. That 4.7 billion includes the 2.9, but also includes income that comes into our providers from outside, where they are treating populations from outside of South West London, whether that be in community services or in acute services or mental health services. So this report is split into two parts. It looks at that internal ICB budget of the 2.9 billion, as well as the 4.7 billion of the whole NHS system for South West London. Just to further complicate that for this year, in the first year as starting out on this journey, obviously the ICB came to be on the fourth month of the year. So the first 3 months of the year was covered by the CCG. So the original budget that was developed and agreed with NHS England for the 2.9 billion annual allocation was taken to the CCG governing body at that time. So when we met as a board in the 1st of July, obviously we hadn't done the accounts for that period of time. As it occurs, due to timing delays, we spent 10.8 million less than we expected in those first 3 months of the year. So to ensure that those £10.8 million aren't lost to the system, and a financial framework was changed within the CCG so that it broke even for that period, and we're looking to move that £10.8 million into the ICB budget to make sure it's still available for us this financial year. So I'm just asking the board if you'd be happy to approve that updated budget for the last 9 months of the year to include that additional extra allocation so that we are working to that appropriate amount. If I then go on to look at the internal ICB budget at month 5, we are showing a £2 million surplus to plan. This is because we are ahead of plan due to £1 million of non-recurrent savings, which we identified earlier than expected. So it's just a timing issue rather than an additional amount. And because there is £10 million of elective recovery fund income that is sat within the ICB that, due to the level of activity being delivered by our providers, hasn't been earned by our providers through the cost and volume contract that we have. That means that money is still available to the system. It is quite complicated at this moment in time about elective recovery fund because NHS England is still confirming what the rules are and the guidance is to be able to allocate that out. But we want to make sure that we have that access to our system so that we don't lose those funds, and that's why that's showing as a surplus in the ICB. Key things to note for the internal ICB budget is that continuing healthcare placements and prescribing remain the key risks to delivering our financial position for the year. If I move on to the ICS, the wider ICS, so the NHS, including the NHS providers as a whole, you will see that they are £10 million behind, which is the equal offset for the elective recovery fund monies. The key risks that remain for us as a system as a whole is around delivering our efficiencies. So there's a significant risk in the amount of efficiencies we need to deliver to meet a break-even plan, as well as having the added pressures of inflation that has come along, and the fact that COVID, as Gloria said earlier, the amount of COVID in the system is a lot higher than was expected when we were going through the planning round, and therefore the plans that were originally done by the NHS and across the NHS didn't take that into account at the time. Finally, I would say that the capital plan is behind budget by about £10 million at the moment against the £128 million we have as a system, largely due to timings of what we're doing, etc. But at the moment we're doing a big piece of work to review that and to see what other schemes are available to us as a system. But I'm happy to take any questions, or Dick, as Chair of Financial Planning Committee, if you'd like to add anything.
Thanks very much, Helen. And following Mercy's example, I might just say a little bit about the Finance and Planning Committee as we've been developing and finding our feet as well. This report is an iteration of previous reports to the Finance and Planning Committee, and further refines it as the information develops. Just on the reprofiling point, that's not been to the Finance and Planning Committee, and in discussion with Helen suggested, but I very much endorse that reprofiling should come here straight away rather than wait another month. And so it seemed to me that both it's something that should be approved and that it's something that should come here swiftly. As Helen said, the committee's challenge in providing useful advice to the board crosses these two different types of system, the board and the system, and actually decision making within the two is rather different. Board, much more traditional ways in which one might address and assure and so on. The system, I think, raises wider challenges that we need to develop as a committee ourselves into addressing, which won't involve traditional decision making, and where we have the additional pressure that, of course, we only exist to create changes, to address inequalities and to shift the way in which we do healthcare. Much harder. So it's something that I've been eager on the committee that we start to ask ourselves questions about how innovation and change informed by finance and workforce and planning issues can help the board with change. And I'd just like to say here that that process, of course, needs to be informed by us thinking in the open and engaging with as many partners as possible. We don't have a good way of doing that yet, but I hope that we'll be able to develop that. And that's worth bearing that in mind as we go on with the more traditional work of assurance and quite a lot of decision making, where work has been done to increase the effectiveness of the assurance that can be brought to the committee when we make decisions about specific expenditure. Turning to what's in this paper, for me, I'm sure not for Helen, but for me, it's been a very interesting experience seeing months sort of 0 to 5. It feels, I never liked roller coasters, but it feels like that long, quiet descent up to the top. And I think it's now, or maybe it's by the next board meeting, that we get the bit that everyone else seems to think is really good fun, where you go whoosh. I'm not looking forward to that bit. But I think we can see in the report that Helen's provided 3 key factors that really speak to that. One is inflation, and that very significant gap of 5% between non-pay costs and the reality of inflation, without even getting into some of the details about health service specific inflation. The second is workforce, where, as partners will know in much more detail, that separation, the growing gap between what would ideally be planned and the agency costs and bank costs is beginning to move towards something that's like when you go over the tip of that roller coaster. And the third area that Helen referred to as well is the £280 million worth of efficiencies, where 32% of those are rated red. And of course, those are always the transformation and change savings are always the hardest to achieve. And so it's a double challenge. And yet for us as a board, and those things are likely to crystallize into an adrenaline rush in the next few weeks. And yet as a board, we have to keep thinking about how we move forward and address change. And it strikes me that Helen's report very effectively shows us the scale of that challenge, and that's something I want to commend to all partners here. Thank you.
Thank you, Dick. And Helen, can I have questions in terms of the finance report? James?
I think it's probably less a question and more of a comment, Dick, on your last point. So, when trying to transact some of that innovation and some of those efficiencies, there's a very clear link between the three. Attempting to sort of buck the trend of inflation, one of the key ways that we do that in the NHS is through pay restraint. Well, pay restraint has a really significant impact on the workforce availability and drives us into temporary staffing, and actually the inability to staff substantively and the reliance on temporary staffing then has a significant impact on our ability to deliver efficiencies, because it actually constrains us in terms of the number of things we can do. So I think that the challenge for us as a local system, for me, is to recognise the relationship between those three constraints, and potentially it leads us into some slightly counterintuitive decisions for me about how we both look after our staff and also deliver efficiencies and innovation, because I think actually I think the overall approach in terms of pay restraint might be giving us a bit of a false assurance that we're actually making ourselves more efficient by doing it. I think we are at risk of making ourselves less efficient.
Thank you, James. Sarah?
Yeah, so mine is more of a comment as well. I just think it's the board needs to be, and I know Helen has set it out in the paper, but I want to be really explicit about the level of risk that we are holding in the system at the moment, because just because we're on plan now, to be clear, our plan is that we're £55 million in deficit at the moment. So we are currently in a deficit position for this time of the year because that's our plan. And the reason our plan sits at this point now is because we are going to have to make more efficiencies at a much higher level for the rest of the year, and that is very high risk. So the reason I'm saying that is that looking at it now, we've got a balanced plan. Yes, we have got a balanced plan this month, but it's unlikely to continue that way going forward into the next 6 months. So we just need to make sure we are acutely aware of that. And as James said, the only way we can make that back is by being more efficient, because we do not have the choice to not treat patients. We do not have the choice to not continue to see people when they come through our doors. So that is a big ask for all of the system, including our providers, who are actually under a great deal of pressure at the moment. So I just wanted to highlight that. There may be some non-recurrent funding in the system that can cover some of that going forward for the next few months. It may or may not cover the whole of the deficit that we need to continue, but that still puts us in a worse position for next year again, because then we'll be running at a rate that we can't afford going into next year. So I do think it's really worth the board really understanding that and taking note of that. So I just wanted to, I know it's in Helen's report, but I just wanted to say it really explicitly so people understood that.
Thank you, Sarah. Can I perhaps just add to that? And again, I think it's linking Sarah's and James's comments, which is, and the conversation that we had about the UEC, that we have to look after our staff if we're going to be successful in achieving some of these aims. And I think we just need to recognise that difficult financial position, the need to look after our staff in this, but also drive some efficiencies through the system. That's quite difficult to achieve in the context of where we're sitting with all of the other factors swirling around. It isn't easy. It's going to involve some quite difficult decisions, but I think it's really important that we note that and the importance in maintaining our workforce in order to deliver our aims. Vanessa.
I think just to kind of add to it, whenever I talk with my staff around efficiencies, they're really up for efficiencies if they can use those efficiencies to treat more patients. The nature of them is, if I can get more people through and treat more people, I'll do it. And that's really positive, isn't it? But the dilemma I think that we leave with our staff at the moment is they do that and they might not be able to provide the level of service at the level that they want to anymore. And we haven't, to be able to articulate a bronze, silver, gold level service and to release the staff from some of that pressure of, actually, we know you want to provide gold or platinum, but actually at the moment we haven't got enough to be able to treat as many people. That's a really mature risk conversation that we're having it in providers. Well, I'm having it in mine, and I know that some are having it in theirs. But actually, how do we bring that to this forum? So otherwise, we'll keep saying that we're going to drive it out through efficiencies, but actually what our staff are really committed to, or my staff, I'll own it, my staff are really committed to is treating more people. That's what they want to do. And I think that's a real dilemma.
Helen, if I come back to you.
Thank you. I think, we are going to have to make some difficult choices, but it is important to support the staff and for the staff to understand exactly that, and that actually we need to try and support as many people as possible. And to do that, that might mean some things we might need to stop doing.
Thank you. Any further questions? Jacqueline?
So I suppose this is our leadership challenge, isn't it? Yeah. To bring all this together and lead our staff through this while supporting them, enabling them, and being clear about what success looks like and what risk we are happy to hold, both at organisation, place and system level, because that's why the risk conversation is probably so important, is that we're not going to be sitting here for the next few years, I think, feeling really comfortable with the risk. And I think that's right that we don't, because it is difficult. But that is what we are here to try and do. And I think that is our challenge about how we support and protect, put an umbrella over our staff while we hold and are clear about the risk we know that they are holding and we are willing to hold with them.
Thank you.
Ruth?
Sorry, Dick.
So I just wanted to come into the, I won't try and get into the finance, but the point you make, Vanessa, about how we make that it possible to discuss different levels of risk, which obviously complements James's point. It strikes me there's something quite important for us to think about as the board. How much more flexibility do we have than was available in the past to try and create a little space for that? Both flexibility in a formal sense of what's allowed, but of course in a wider sense about what seems reasonable to people in southwest London, because none of these will be easy things to do. But I'm struck that us putting together that equation and making judgments that feel viable to everyone who really knows the system, and help us have a little more space to help staff feel they're moving forward and innovating positively rather than just innovating to close down, must be a significant part of our work going forwards.
Thank you. Dagmar.
Yeah, and I think that's where, in a way, system and place comes in as well, because as we've said before, the worst would be that everybody puts their shutters down and says, I want to shed risk and pass it on. That is the worst. And so being really transparent amongst all the partners, what their financial pressures are, what their absolutely statutory duties are, and then saying jointly, how can we get best benefit of what we have together? It requires a lot of, I think, openness, so that we are not inadvertently trying to just look after our own.
Thank you. And I think that probably links to something that the board will need to reflect on, which is how do we do prioritisation? How do we make some prioritisation decisions, which I think, again, is probably something in terms of the development of the board that we'll need to reflect on and spend some time thinking about. So, Ben, I'm just going to check with you, because I think as well as noting the paper, we've been asked to approve the ICB internal budget for months 4 to 12 and note the change in profile across quarter 1 vs quarter 2 to 4. Can I just check that we're quorate to do that?
We are.
Thank you. So, is the board happy to approve the reprofiling and note the report?
Yes.
Thank you. Okay, item 12 on our report. So I'd like to bring in our Health Watch and voluntary sector representatives. So I think we've got Simon Breeze and Liz Meribel, and give them an opportunity to ask any questions about what we've discussed today in the items on the agenda.
Sorry, I need to move this a bit further, being a short person. Yes, I wanted to take us back first to the item on virtual wards and pick up a few issues from that. Firstly, pick up on the point that Dagmar was making, which I thought was very important, about the public and patient engagement in relation to virtual wards, and indeed in relation to any changes and innovations in service delivery, because the more that it is discussed with patients and other members of the public, the more likely it is that there will be buy-in, and that the innovation will achieve its aim. And we had a presentation in Kingston on the virtual ward scheme there, which was in many ways very useful and very reassuring. However, I think we were surprised that the scheme was only in operation from 8 a.m. in the morning to 6 p.m. in the evening, and that did seem to leave, a very long night, particularly in the winter, and potentially you know, if we think that some of the origins of virtual wards are around managing anxiety, that did seem to be quite a period of time for it not to be in operation. And I think that picks up on Mercy's point, which was that evaluation should include the impact on people who are alone at home. And also at our meeting, we asked for the impact on carers to be taken into account. And I also want to pick up a point that Marion Endicott, who is the patient representative at the ICS Quality Council, made on the 9th of September, that the impact of the cost of living crisis on patients with long-term conditions should be taken into account. And, you know, particularly if we're looking at reducing length of stay, there may well be an issue for quite a lot of people about the heating in their homes. So in this continuous quality improvement process, please could those kind of issues be fed in to the evaluation as it proceeds, because 18 months does seem, you know, quite a long time period. So if those could be fed in as it goes, that would be useful. The other point I just wanted to raise is a general one about the statement made about patient and public engagement in the cover sheets of these reports. I think it is the same statement that was used in the merged CCG, and it is a fairly general statement. And I was prompted to look at this in relation to the item on winter preparedness, where there was an event on the 30th of September, and I was just wondering whether there was any PPE at that event. But I couldn't really tell from looking at the cover sheet. So perhaps if the board could give some thought about the statement about PPE actually being more tailored to that particular paper. And sometimes PPE may not be needed, and that would be fine, but where there is some, please could that be more specific? Thanks.
Thank you. Sarah, could I ask you to come back and respond on both of those points?
So there's quite a few points there. I'm going to go to some different people for some of it. One, I would say, on the virtual wards, it is intended for them to be 24 hours. They're just building up to that. That's the first thing. So it's not that they will be just 12 hours. And just to be really clear, those are only for people being discharged from hospital under a clinician. So we won't be talking to the general public about it as in you can access this, because people won't be able to access it in any other way other than being discharged from hospital under clinical supervision by a senior clinician. That's the only way people can access that. So, and we will go back and ask Liz about the public and patient engagement, but I do know they've got lots of positive feedback from the patients in it, because once you're in it, then that's where they get the engagement on, and that will be part of the evaluation. I think we've already covered earlier the bit around evaluating the impact on others around them and carers and so on, so we will make sure we pick that up through that process. I'm not sure what we do on cost of living, to be honest, because I think it's a problem for everyone, but I'm going to come to two people. I'm going to come to Charlotte on the cover sheet and anything else she wants to mention, and Jonathan on the urgent emergency care event and who was actually at the event.
Yeah, thank you, Liz. So I think we do need to make sure that patient voice and community voice is actually, you know, really part of what we do, and that we hear patient voice and community voice through all our programs. So on the virtual ward, you know, Healthwatch have been involved, but I think you're right in terms of the evaluation, but also that real-time feedback. So we'll work with Martin's team to make sure we kind of bring that together. I think there's two things really on the virtual ward. The first one is with those patients who are targeted to kind of receive that service, but then the second part of it, as Dagmar was saying, is about talking to people in the wider community and helping people feel confident about a virtual ward. And we'll be, we've got that in our kind of winter plan to talk to people about it. And I think actually for staff as well, well. I think it's good for staff to hear about the innovative things that we're doing to support people on the front line. So I think it's kind of, you know, double-pronged really, in that we're talking to people who might experience or be offered a virtual ward, but we're also talking to staff about the different ways and the innovative ways we're working. So patently, we do need to look at the PPE section, you know, in the papers and make sure that the decisions are informed by community voice, definitely. And I'll let Jonathan come back on the winter piece.
Okay. Thank you, Liz. Thanks for the question. So for both events, we did have patient representatives there. We felt that patient voice was really important to have at both those events. So there were a number of people at both those events. I know that because I spoke to them. I can't give you everyone's name who was there, but we can find those out. And there were, at both events, I'd say around 60 to 70 people there across the whole breadth of the system, through local authority colleagues, through the whole emergency pathway from primary care, through secondary care, hospital doctors, through chief executives. Chief executive of the Ambulance Trust was one of those sessions. All the chief executives of the Acute Trust were at the first session. So there's really strong representation at sort of all levels across the system there, given the priority that we as this board have just noted, and we all feel personally actually about addressing the issues we've got around urgent emergency care. So happy to share the names, Liz, if that would be helpful, but it was certainly there.
Thank you. Simon, could I come to you for questions as well, please?
Thank you. Just one from me. So it links into the thing about resident engagement. So, and it's about the local place partnership boards. So I've kind of raised this at a local level, but it's something that South West London colleagues, BCS colleagues have also raised, and that's that it's very difficult for us who have seats on those boards to engage and involve the wider BCS, and again by extension people they work with and represent, if we can't share those papers. So I understand the need to not create lots of layers of meetings and bureaucracy, but I think it's unrealistic to expect people at a local level to come to this forum to kind of find a way into what's happening with the ICB and the ICP, because it's quite abstract at a local level. At this level, I think people are just not going to engage. So, yeah, I know there are some difficulties there, but I think it's something we need to kind of crack in order that we can kind of do our role. That's it.
Thank you, Sarah.
So, I mean, I'm happy to talk to, and then there are place representatives here on you know, what we can share, because we can't not share anything. There must be things that where you want to go and talk to people that can be shared. So I think it will just be about them working with you to work out what can and can't be shared, because there will be some information that, you know, if you're in that kind of working group that you can't share externally, but there must be stuff as well that can be. And I think that James is a place representative might want to.
I mean, I think that it's always a real challenge, Simon, with the scale and complexity of the system and the number of different groups in terms of kind of trying to take everyone with us. I think that for example, for Sutton, with myself as the ICB rep, and then with Dino as the ICP rep, you know, the challenge for us is to continue to keep feeding into the local system, and I think it's our job then to make the link. So, you know, actually when we are, for example, talking about virtual ward, I know we've had extensive discussions about virtual ward in Sutton, so it's sort of, you know, trying to help, I suppose, everyone to kind of hold it all together and focus on the bits which are of direct interest and relevance to them, because there's a lot going on, isn't there? And I think that's as we sort of evolve into this new model, I think that's the thing that we'll need to continue to work on.
Thank you, Charlotte.
Yeah, I suppose it's just building on what James is saying. So we are in a new model, and I think we have to make sure that both Healthwatch and the voluntary sector representatives at place are equal partners. And I think that's a journey we need to go on. But I know the intention is there from all of the place leaders to make sure that you are sat at the table and involved. And we just need to get the processes right so that you can go out to your kind of wider constituents, if you like, and flag those issues ahead of time. Because I recognise that you don't have the infrastructure that the NHS and local authorities have, so you need time to be able to flag the issues with your colleagues and have those conversations. So I think we can have, conversations locally, and I know you're not just talking for Sutton, you're talking for all of the places in South West London. So I think we need to kind of work harder on it and make sure we get it right so that you have the time and you feel that you can make the comments and contribute to the decision making in the right way.
Thank you. So I think good commitment there to work with you to try to address that issue. Thank you. So could I ask whether there is any other business that members of the board would like to raise? I nearly got to the end. Thank you. So I think that draws the board to a close. We now have time for public questions. So members of the public were invited to ask questions in advance by email relating to the business being conducted today. There were no questions by email. But I think we will now take questions from any members of the public that are present here today. And thank you for putting your hand up. If you could just introduce yourself as you ask your question. Thank you very much.
Good morning. My name is... Okay. My first name is Rob and my surname is Rob. I'm a resident of the South of the Borough community for Royal Borough Kingston. I am also a member of Health Watch. I'm a member of the Chesington District Residents Association. I'm also sit on the Kingston and Richmond Local Pharmaceutical Committee as a member of the public, because they do allow the public there for get feedback, etc. And I think that's it, really. My first, can I ask more than one question? Is that allowed? I've got to say, I must commend you on your chair of this meeting. It's brilliant, thank you. My first question is that, it's an old chestnut, as you know, is that you mentioned earlier that although things are going to happen next April, need to be talked about now and be well underway. So therefore, you should be talking to pharmacists and dentists now, not waiting until next April to implement things. I believe that the commissioning of services for pharmacy, dentistry, physiotherapy and optometry, is it? All run by Jeremy Woolman, one person. So you can talk to one person about all these services. As I go to the local pharmaceutical committee, I know what's going on with local pharmacists. And Councillor mentioned about the local pharmacist's role is very important, especially when a lot of services are being devolved to local pharmacies. But so the first point is you should be talking to them now, and they should be included. They should be sitting around this table. But I've been talking to dentists, and it's an emergency with NHS dentistry. The actual problem is now. And when you speak to them, the main problem is they've been waiting for the new contract for ages now. And if they knew that the new contract actually reflected when they do like a root canal, they get more money for that than they do for an oral extraction, which they don't at the moment. It's all like one charge. If they knew they were going to be paid properly for the job, hopefully we can stem this migration away from NHS dentistry. So you can't wait till April, as you say. You've got to start talking about things now. So I would ask, is the new contract available for dentists?
Thank you. So I think there's two questions there. Sarah, do you want to either answer them or just...
Yeah, no, I'll give these ones a go. So welcome, thank you very much. So yes, there is a plan to move the commissioning of pharmacy, optometry and dentistry to ICBs in the future. We're just working, and so we are working with the teams at London. Currently it sits with the NHS England, who are running from London those services. So we are talking to them now, and we are trying to understand what that would mean for us to have the delegation and how we would take that forward. So just to give you some assurance that, and we've had a sort of seminar discussion, and we'll be doing a similar process to the one that we're doing on specialised with the pharmacy, optometry and dentistry as well. On your second point on dentistry specifically in the contract, I would agree the contract is a problem. It's a national contract. We do not have control of that contract. It is a national piece of work. I was assured a few weeks ago that this was an area that they were looking at nationally and that they would be looking to have a discussion about the contract at some point in the future. But I can't give you any more detail than that because I just don't know, Robs, but I'm sure that it is an issue. I would agree with you, but it's not something that we can solve within this ICB or any ICB actually. It is a national, in the same way as general practice has a national contract, so do dentists.
Yeah,
Thank you. I just want to ensure that we ask if there's any other questions, if that's okay. Thank you. Are there any other questions from members of the public?
Right. Oh, thanks for that, because as you know, if you tell me where the problem lies, I will go and deal with it with that. So I'll do that.
I'm not sure if it's the Department of Health or NHS England, but it's definitely national. So
But we've asked time and time again for Jeremy to come and meet us at certain local meetings, and he doesn't even reply to emails. So I know it's not your problem. My second question is maybe we should change the PPE terminology because I get confused from personal protection equipment but at the moment it stands for poor patient engagement. It's a disaster at the moment. I sat on the first few Zoom meetings setting up the ICS, and I was really excited about all this going on and bringing all the services together. And I thought it's a fantastic thing, the 10-year plan. But I soon found out that really it was a steering committee. It's not a consultative committee. And since then, our PPG seem to have died. Our PCN is not a true PCN. We're sort of in Chesington, and we're not actually put with the other Chesington practices. We're stuck with another practice on the north because we're owned by Churchills. The GPs have decided it's easier for them to be involved with their own sort of owner of their practice. So we need to revisit the whole patient participation thing. Get PCNs to reflect, because I think you're talking about making PPG start talking to each other, which is an excellent idea, which, getting PPGs together. But we wouldn't want to be included with the PCN PPGs we've got, because they're nowhere near us. We'd like to be included in, so maybe, in that case, maybe the PPG sort of meetings, you don't do them on a PCN basis, you do them on a local basis, that the surgeries are included that are local. I mean, one of the sort of sad things about it all is the people that have antagonised patients more than anybody are GPs. With introduction of the online, and I'm sorry to bring him into, but I'm talking to the IT expert over here just now. He's having trouble actually getting an online appointment with his GP, and he's an IT expert. You haven't really catered for the people that are are not computer illiterate or literate. Sorry. And we've got to get back to, well, at least we had the primary care CCG meetings where we could sit there and ask questions and actually get our views across. We feel totally isolated, and it's urgent. You've got to do something about patient participation. It's important.
Thank you. Sarah.
So PPGs are still a requirement of general practice. So these are patient participation groups that sit within general practice. So they're run by general practice, and I know you're part of your local PPG, and your practice should still be continuing to run that. PCNs were self-selecting, so PCNs also were self-selecting around who they worked with and the group coming together. But what I can do is I can take that back around your view of how it's currently working around your PPG and your PCN, and this idea of having slightly larger groups. I'm happy to take that back to our local practices, our primary care teams, and make sure they engage with the practices to make that as a suggestion about how you might work in the future, because I think it sounds very positive. Charlotte, did you want to say anything on that?
Yeah, I suppose just to come back, that maybe we need to have another conversation, because I think that we are in a new system. We want patient and community voice to be heard, but what we haven't done is set that as a mandate from South West London and said this is how 6 places must engage with their local communities. So we have got a bespoke engagement plan for each borough, and we need to talk to you about that and check that you feel your voice is heard. So let's have a conversation afterwards and we can talk to the engagement lead in your place to make sure that that's happening. But I suppose what I would say is bear with us. You know, we are setting up new systems and processes, and we want to get it right.
I really appreciate it. Thank you. Can I be cheeky and ask one more question then, because nobody else is asking?
Okay, one more question.
I know, excellent chairing. Thanks very much.
I know, you've already buttoned me up.
It would not have happened at the last meeting. Right. You mentioned there's a capital budget, right? Can I, it seems we've got, the orchard practice needs new premises somewhere. It's been on the books for years now, right? And we were top of the list at one point to be replaced, you know, a new replacement thing. There seems to be quite a healthy amount of money in the capital budget. Can we ask that the orchard practice is looked at again, and I believe now they're not shouldn't be called practices anymore. We should have our local health centres, because that's what they are now. They're not just a GP practice. They provide near patient testing and everything else. And they're a place to go for, not just to see a GP, but to a general health problem. So if you can spare a thought for the orchard practice in Chessington, we very much appreciate it. Thank you.
I'm sure the orchard practice will be very thankful to you, Rob. We do have a process around capital and around how we allocate that. So at primary care, there is a process around primary care allocation for capital. I don't know where that is in you know, we're talking about the orchard practice, and I can't answer that now, but we will come back to you on that and just work out where it is in the process.
Thank you very much. Thank you.
Thank you. You're welcome. Thank you for taking the time to ask your questions.
So since Rob is being cheeky, perhaps I could be just cheeky as well and say that actually it is true that the orchard practice was at the top of the list in Kingston for looking at the primary care estate. So that was indeed the case. And in relation to the PCN, that is an ongoing point that Rob is raising, and what we said locally at Healthwatch, and I think it would apply to other boroughs as well, is that it would be great if the PCNs, as much as possible, are coterminous with the local authority subdivisions, which certainly in Kingston are called neighbourhoods. They may be elsewhere, because given the local authority role with public health, having that kind of coterminosity would really feel like, you know, a real gain in terms of driving forward the public health agenda at PCN level. Thanks.
So yeah, so the issue that we have is that PCNs are self-selecting. It's GP practices that select it. They don't select it based on. So we cannot force them to go into partnerships with, you know, in certain geographical areas. That's up to them, as long as they can evidence that they're meeting a kind of level of population. And that they can work together. That's the kind of overarching requirement around PCNs, not to be coterminous with local authority boundaries or anything else like that. Well, they have to be within a local authority, but they don't have to be coterminous with the boundaries within a local authority. So there is nothing that we could do to kind of, I mean, it is something that if they felt would work for them and that they could work with, I'm sure it's worth the discussion with them, and happy for my team to be involved in that, but we can't actually enforce that.
Thank you. So on that note, I'm going to draw the meeting to a close. Thank you very much for everybody for attending, and thank you to all of the teams that have put so much work into the papers. So if people could pass on my thanks as chair, that would be fantastic. Thank you.